Hi all, and welcome to the Medical AI Lab talk series. I'm delighted that today we have Dr. Andrew Lee present AI and Colonoscopy. Looking forward to your talk, Andrew. Take it away.
Thanks for an introduction. I'm a GI fellow here at Stanford, and this is a subspecialty within medicine that focuses, as kind of the name implies, on the digestive tract. And as a part of our practice, we do endoscopic procedures, colonoscopy included. And so today I'm going to be discussing, kind of reviewing recent work, looking at AI and colonoscopy. And if there's some time at the end, I'll review other applications of AI within endoscopy in general. So by way of background, let's start with colorectal cancer. So colorectal cancer is the second most common cancer in the US and the third leading cause of death, with about over 100,000 cases per year and 50,000 deaths per year, respectively. To kind of put in more concrete numbers what the risk of this is, it's about 4.3% for men and 4% for women. So somewhere between 1 in 23 and 1 in 25 in the US population as a whole. So it's a fairly common cancer. And for that reason, there's been a lot of work over the past several decades looking at what can we do to prevent death from colorectal cancer. And the main thing that's been introduced is colorectal cancer screening. So the principle behind this really gets back at this adenoma to cancer sequence, where if you have a normal colon lining, there's a small percentage chance over time that you can develop some hyperproliferation, which can develop into a polyp. Once you're at an adenomatous polyp, this is considered a precancerous lesion, and a small percentage of these will go on over time to develop into, frankly, cancer. Cancer, if caught early, can be cured, but once it's spread, it's usually not curable. And for that reason, screening plays an important role, because if you can intercept this process early on when it's still a polyp and not a cancer yet, you might be able to prevent cancer by removing the polyp before it has a chance to turn into cancer. Or in the case that it has become cancer already, if you diagnose it early, there's a chance, for example, curative resection as opposed to more palliative approaches. And so the latest guidelines were actually just updated last year by the US Preventive Services Task Force. And historically, screening's been recommended for all adults ages 50 to 75, but what changed last year is they've lowered that to include ages 45 to 50 as well. There's a couple ways that colon cancer is screened for, broadly divided into stool-based tests and direct visualization. Stool-based tests look for traces of blood or small pieces of DNA combined with the traces of blood that might suggest there's an advanced polyp or cancer. And then the direct visualization tests, the primary modality is colonoscopy, which we'll talk about in a little bit. But less commonly used are also CT colonography, where there's a CAT scan that's done and 3D reconstruction is recreated. And then finally combining flexible sigmoidoscopy, which is sort of an abbreviated colonoscopy, where you just look at the last foot or so of the colon plus a stool test. The one thing I'll say here is if any of these other modalities end up positive, you end up at a colonoscopy to kind of directly evaluate, because false positives do exist, and you can have, for example, blood in the stool for other benign reasons, such as hemorrhoids. So with the advent of an introduction and uptake of colorectal cancer screening, there's been a reduction in incidence over time. In the past 30 years in particular, you'll see since about 1990, you have this sharp decrease in the incidence of colorectal cancer in both males and females. The decline prior to 2000 is mostly attributed in the literature to changing patterns and risk factors, such as smoking, combined with colorectal cancer screening. But the accelerated decline you see since the year 2000 is thought to mostly reflect the uptake of screening, primarily the colonoscopy. And to kind of give you a sense of how much screening there is in the year 2000, about 20% of adults who have an indication for screening were screened. Now it's about 61%. As discussed before, you might imagine there's a little bit of a lag time between your intervention of screening and when you see a benefit in terms of cancer reduction, given that it takes about 10 years to progress from a polyp to cancer, if that polyp was destined to progress to cancer. So what is a colonoscopy? It's a procedure where an endoscopist uses a scope. It's controlled by the endoscopist with a couple of dials and torque of the scope itself. And at the end of the scope here, this is what it looks like. You have a video camera lens, light, and an instrument channel. And through this instrument channel, various devices can be fed to, for example, remove polyps or biopsy anything that's suspicious. And during the exam, what you get is about 30 high definition frames per second of pretty rich visual data to both help guide what you're doing to the procedure, but you also simultaneously have to closely inspect it for things, for example, as polyps. If polyps are removed, these are sent to the pathologist for a look under the microscope to provide a histologic diagnosis. There's about 16 million colonoscopies per year performed in the United States alone, so it's a fairly common procedure. So when a colonoscopy is done for colorectal cancer screening purposes, what you're looking for are colon polyps or cancer, if that's developed already. But usually for a screening colonoscopy, if you do find anything, it's a polyp that hasn't progressed to cancer yet. These can have a variety of different appearances, some of them more obvious than the others. So for example, in panels A and B, these are fairly obvious polyps. They're sticking up. In A, it's pedunculated on the stalk, sticking out into the lumen of the colon here. B, this is probably a semi-pedunculated polyp, again, fairly large, sticking out into the lumen. But the remainder of these polyps are a little bit more subtle, which I hope you can appreciate. So for example, in panel C, this is considered a relatively fat, flat polyp, but if you look closely, you'll see that the color and pattern of vessels and what's called the pit pattern overlying the polyp is a little different than the surrounding mucosa. And there's a couple other examples here. Again, some of these may even be semi-depressed. In G and H, these are kind of relatively larger polyps, but you might appreciate a difference between G and H, for example. So H is kind of sticking out, an elevated polyp out of the mucosa, whereas G, if you kind of look closely, there's this kind of scalloping granular pattern here that I'm outlining, which is, you might be able to appreciate is a little bit more of a subtle finding. On the whole, all the polyps shown here are relatively large, probably all of them at least 5 millimeters or greater. Some polyps are as small as 1 or 2 millimeters. And so really, one of the challenges in colonoscopy is really just to identify the polyp. And so that's actually been a major area of focus in terms of quality improvement for colonoscopy. And there's a metric that's tracked called the adenoma detection rate. So if you recall, an adenoma is a precancerous lesion or polyp. And based on kind of large scale studies, there's a recommendation from our societies that at least one adenoma should be found on average during screening colonoscopies in 30% of men and 20% of women, or 25% composite. The reason this recommendation was made is that there's fairly good body of evidence showing that there's a strong inverse relationship between adenoma detection rate, or ADR, with the risk of interval cancer, and to kind of give you a sense of the magnitude of it. So for every 1% increase in ADR, there's a 3% decrease in interval cancer risk before the next colonoscopy. If you compare the bottom quintile of colonoscopists with the top quintile in terms of ADR, the risk of interval cancer is roughly double. You see similar benefit in terms of colorectal cancer mortality as well. And so there's been a lot of focus on improving ADR, and there's been interventions done, for example, with education about how to more closely inspect mucosa. And it's been shown that if you improve ADR, your risk of interval cancer decreases as well. So does mortality. There's been things like mandating a minimum withdrawal time, so how long it takes for you to actually look and inspect your mucosa. As you can imagine, if you go too fast, you can't get a really good detailed look. There's also been a lot of devices that I've kind of highlighted a few here, and advances in endoscopes to help improve visualization. And so one of the big improvements was the introduction of high definition endoscopes. And so you're going from kind of these grainy images to now basically 1080p images, and you can see these smaller polyps a lot more easily. There's also these mechanical devices here that I pulled from this review, an endocuff or endoring. And the way these basically work is that they help to flatten the mucosa, flatten folds, and so that you're more likely to see polyps that might be hiding on, for example, the edge or the backside of a fold. And then finally, there's this colonoscope shown here in the rightmost panel called a full spectrum colonoscope. It's not used very widely, but essentially what it is in addition to this forward viewing camera, you have a camera on the side of it as well as on the other end. So there's 3 cameras, and it gives you greater than a 270-degree view. Again, this is to kind of improve mucosal visualization. Separate of this, there's also been some studies, interestingly enough, that showed that if you have a trainee with you while doing a colonoscopy, your adenoma detection rates improved. And this might just because, the trainee might be a little bit slower, you get more time looking, but you also have another set of eyes. And it's really kind of for this reason, I think that AI for computer-aided detection has caught on in colonoscopy, because as you can imagine, you're kind of, while doing a colonoscopy, you're multitasking to some degree, you're controlling the scope, you have to make sure you look behind folds as best you can, clean things, but also keeping an eye on all parts of the screen as best you can for sometimes relatively subtle findings. And I think that's really where deep learning might play a role here. And so in colonoscopy, broadly speaking, there's kind of 2 main areas that folks have been working on. The first is computer-aided detection, and the second is computer-aided diagnosis. So what's shown here on the right is just an example screen capture of what most CADI systems are doing these days, where they put a kind of a bounding box around these 2 polyps here. You might appreciate these little relatively small polyps that are seen here. But, and that's kind of what I'll focus the majority of the talk on. But an area that's kind of an active area of investigation now is computer-aided diagnosis for classification. And one of the hopes here is that it might allow for quote unquote optical biopsy. And the reason this is of interest is, as I mentioned before, every time a polyp's taken out, it's sent to the pathologist to look at under the microscope to provide a microscopic diagnosis, which is thought to represent something like 10 to 15% of the cost of colonoscopy on the whole. And so this is a potential area for cost savings. And the reason that's done is because there are different types of polyps, and you want to make sure that there isn't cancer hiding within the polyp. So I've pulled some sample images of polyps here. This polyp here in the top left is what's called a hyperplastic polyp. It's considered very low risk for malignant potential. And if it's in the left colon, these are usually actually not even resected, they're just left behind. These next 2, the top right and the bottom left, are adenomas, the primary polyp we've been speaking about. And then the last one here is actually an early cancer. There's some features of it that suggest early cancer endoscopically in terms of the vessel pattern and pit pattern. And what studies have shown is that if you look at experienced endoscopists or expert endoscopists, they have about an 80% accuracy rate of kind of differentiating between these. But what the societies have proposed is that if a 90% accuracy could be achieved, that might be a reasonable threshold to adopt a kind of quote unquote resect and discard strategy to help guide when the next colonoscopy should be. I'm going to show just a couple examples of what these systems look like in real time, and they might also provide a sense of what a colonoscopy looks like in real time. So the endoscopist here is withdrawing the scope, and there is a polyp there on the right side that you can see that bounding box highlighting. I'll play this again. You see how the initial withdrawal is kind of subtle. Once you're closer, it's a little bit more obvious, but this is how most implementations of AI-assisted colonoscopy work. Here's another example. Similar idea. There's a polyp on the edge of that initial fold there. And I think what's worth mentioning here is that, it's relatively subtle. And if your attention is elsewhere, you might fly by that and not pick it up. At the same time, there's also a piece of debris on that fold that was towards the right of the screen here just a moment ago that it didn't detect. And, the system didn't flag that as a false positive. So, in addition to that, there are some potential other pitfalls, mostly related to debris or light artifact or bubbles. And shown here is a bubble here that's been flagged as a false positive. So this is one of the areas within AI where there's actually been a fair number of prospective trials. And this is pulled from the review paper that I shared. But this is, at least as of the time of this publication of this review last year, all the prospective randomized trials for CADI and colonoscopy. Some of these are non-blinded, some of them are single-blinded, and two of them are double-blinded. And kind of the takeaway here is that if you look at this column, the ADR, the adenoma detection rate, that's kind of the primary outcome for most of these papers. You'll see that in the CADI group versus the control group. The CADI group had a higher adenoma detection rate. Again, as reference, what the ASGE Society has recommended is the ADR greater than or equal to 25% in all comers for screening colonoscopy. And you'll see that in all of these, they've kind of exceeded that threshold with the exception of this trial here, where the ADR was on the lower side. As another point of reference, at Stanford, I think the ADR that we published recently was 44%. So although this is pretty good, could be better too, but there's a lot of factors that play into ADR. What's also worth mentioning here is the withdrawal time. As you might imagine, if you have a system that's flagging potential things you missed, it might prolong the procedure time. So the withdrawal time is defined as the time to inspect the colon during the withdrawal phase of the colonoscopy, and that's really when the close mucosal inspection's taking place. And there usually is an increase in most of these trials, slight. On the whole, it's on the order of a minute to most about 2 minutes across the board, but in most of them it's less than a minute. So it's not a substantial increase in procedure time. I think what's also worth mentioning here is that the kind of architecture used across all of these, they're basically all based on convolutional neural networks of some sort. SegNet, YOLO, some of them are proprietary and not much is kind of disclosed. But by and large, that's kind of the architecture that all of these implementations have used. I'll review a couple of these a little bit more in detail, but this is a kind of a meta-analysis of these prospective randomized control trials, and you can see that the overall effect was about a 48% increase in the adenoma detection rate. Most of that increase in adenoma detection was in smaller adenomas, and in GI that's defined as less than 5 millimeters, but there really wasn't much of a difference for larger adenomas or cancer. That's worth mentioning because it's one of the things that's a little bit controversial in the field is if removing small adenomas makes a difference or not. But for what it's worth, most of the signal here is driven by the small adenomas, which I think makes intuitive sense. These small adenomas tend to be, of course, harder to see. If there's a very large polyp, it's hard to miss. With or without AI or second observer, or what have you, would probably be easy to catch. I'll just highlight two trials in particular. This first one here was a single center study out of China. It's one of the two double-blinded randomized trials, and the study design to make it double-blinded was a little bit interesting, but I think it was probably one of the few feasible ways to achieve this type of study design. So what they essentially did was they used this CADI system, endoscreener, which is based on SegNet, but they also had separately a sham system where they basically trained it on a much smaller subset of the data and tuned the parameters such that they had a similar per frame specificity, but very low sensitivity. And as the endoscopist was doing the procedure, what they were viewing is kind of their standard screen, but there was a separate person in the room who had a screen with the output of one of these two systems, whether endoscreener or the sham system. And what they would do is they'd monitor for these bounding boxes or flags to occur. And if the colonoscopist was about to exit the field of view of what that alert box was highlighting, they'd actually point with a laser pointer at the screen to have the endoscopist go back and look. And so in this manner, the colonoscopist is blinded to what system's being used, and then the data analysis, the analysis is blinded to which group each patient was randomized to as well. And so within medicine, the double-blinded trial is considered the kind of gold standard, if you will, to try to isolate the effect of different interventions. And with this relatively higher quality study design, they showed that there was an increase in adenoma detection rate of 34 compared to 28%. Another thing these studies report is polyp detection, which includes other types of polyps, such as hyperplastic polyps. But the main thing that primary outcome is primarily going to be adenoma detection rate. I included this other table here on the right to kind of highlight what types of polyps that the AI tended to pick up that the endoscopist missed. And if you look at polyps and adenomas, these tended to be the same color or isochromatic. They tend to be flat. Some of them had unclear boundaries or were on the edge of the visual field. And those were kind of the reasons based on expert review of the video footage afterwards for why is missed. And I think this kind of highlights where these type of AI-assisted colonoscopies can really shine. It's to pick up kind of these polyps that have these features that make them harder to identify. The remaining kind of 3 sections here are things kind of more related to technical aspects of the procedure itself, whether it's the withdrawal technique or overexposure, or if there was debris on the lens that made the image subpar. Another trial that I'll highlight here, this is a US-based study, and it was an interesting design in that it's called what's a Tandem study. So for this study, a given patient would undergo a colonoscopy with either standard colonoscopy or with CAD-E first, and then immediately upon completion of that colonoscopy, the scope is reinserted and then repeated with the other method. And so what you're comparing here is whether the polyps were found on that second colonoscopy, and if polyps are found, those are considered missed polyps. And so what's reported here in this chart on the right is the polyp miss rate, the adenoma miss rate, and the sessile polyp, which is another type of polyp, sessile serrated polyp miss rate. And because it's a miss rate, a lower rate is better. And so for patients who had a CAD-E colonoscopy first, you'll see that in 20% of patients, there was a adenoma missed, versus a standard high definition white light colonoscopy without CAD-E first, roughly about 30%, there was a missed polyp. These differences were significant across all groups. These sessile serrated polyps are not as common, and so there's a little bit more noise, but this was still statistically significant. So in kind of summary for colonoscopy, we've kind of discussed primarily the evidence for polyp detection because that's where the greatest body of evidence is in terms of randomized prospective trials. And I think across the board, it's shown that if you add CAD-E, it can help your adenoma detection. But I think it's still a little bit of an open question of if it can help with the detection of these larger, flatter polyps, but at least for these smaller polyps, that tends to be driving most of what the improvement in ADR is derived from. The other section I didn't discuss too much, mostly because there really haven't been any trials for this. It's kind of an area of ongoing need, I'd say, but this threshold of 90% or greater accuracy for or negative predictive value suggested by the ASG for a resect and discard or diagnose and leave strategy for small polyps has been exceeded in kind of the experimental setting, but I think has yet to be shown in more robust real world scenarios. A few other things to discuss just in terms of kind of future directions for the field. So data sets, there are several publicly available data sets, but the vast majority of studies in the field are published with private data sets. And as you can imagine, annotating videos or images is, it's not a trivial task. It requires expert input. And then finally, kind of standardized metrics. Although ADR is very commonly reported, most of the other metrics aren't reported across all studies. And so it's hard to compare these. And kind of related to that, there's not many head-to-head studies. That said, I think when I last checked, there's 8 approved CADI systems. I think only 1 in the United States, but these are being brought to the commercial setting already. Finally, just to kind of round things out, I thought I'd discuss a few potential other applications of AI within endoscopy and GI in general. I've separated this into upper GI tract and lower GI tract from this review at the bottom with that's linked kind of the relevant references here. So within the upper GI tract, defined as the esophagus, stomach, and first couple centimeters of the small intestine, there's a couple other diseases and disorders where there's been a fair amount of work. The first 3 of these are related to cancer detection or precancerous lesions. So Barrett's esophagus is a condition of the esophagus that increases the risk of cancer. In clinical practice, what we do now is we take biopsies every 1 to 2 centimeters, depending on your risk factor. And we take 4 biopsies every 1 to 2 centimeters. So in someone with a long segment Barrett's, you might imagine that could be something like 40 biopsies that the pathologist has to do under the microscope, and then you then randomly sampling. So while we take a close look to find any areas that are suspicious for dysplasia or more concerning lesions, sometimes these are very subtle, and there's a potential role, I think, here for AI to help identify these more subtle lesions. Similar principle for esophageal squamous cell cancer. Some of these findings are a little bit more subtle, and gastric cancer. There's also some work done in sort of subcategorizing these lesions in terms of, for example, depth of invasion. And the reason depth of invasion is important is that it can guide therapy, whether this lesion can be taken out endoscopically or if they have to go to surgery. And again, there are some endoscopic features suggestive of this, but some of them can be subtle. Finally, within the lower GI tract, we spent most of this talk dealing with colorectal cancer screening, but another area where it's really being applied and is a large area of investigation is inflammatory bowel disease. This is a collection of diseases, primarily Crohn's disease, and ulcerative colitis, where there's chronic inflammation over time. And colonoscopies are repeated both to track response to treatment and degree of inflammation, but also because these patients have a high risk of developing colon cancer to the point that colonoscopies are repeated every 1 to 3 years, depending on their kind of individual risk factors. And sometimes it's hard to discern these areas of dysplasia or precancerous lesions in the background of chronic inflammation. And so that's really all I have for today. These are some references that you can feel free to refer to for some additional reading, in addition to the references I included on the previous slides. Now I'll take any questions.
Awesome. Thanks a lot, Andrew. This was great.